Neurology, and my friend in the Cancer Center, Michael.
Thank you, Rolf. When I prepared the presentation, I looked obviously at the one that's 1 year old, and I noticed that we have significant new data, but not all the data is really the way they should be. So, oops, what have I done now? This is back. Thank you. So I would like to address 4 topics. The first one, antibody-drug conjugates, is not really what most of us think about if we think about immunotherapy, but it has played quite a role in the glioblastoma field in the last 2 years, and therefore I would like to quickly show you what's ongoing. I will share some new checkpoint inhibitor data that are difficult to digest and to understand, and that the interpretation is still a bit open. There are new ideas about vaccines and some initial experience with CAR T cells. The first story is about antibody-drug conjugates, and as I say, I include it here because an antibody in the end is something immunological. We had a very promising compound. This is ABT414. This is an antibody that is directed against EGFR, but only if EGFR is overexpressed and in what is called the active conformation. And there's a lot of debate what that really means on the molecular level, but there are antibodies that only recognize this active conformation that is linked to a potent toxin. And this drug went into a clinical trial after a few responses, like the response rates we have seen in head and neck, were seen in recurrent disease. This is EORTC 1410, and the data on this trial are in the public domain. So this is the first recurrence of EGFR-amplified glioblastoma with ABT414 alone or in combination with temozolomide, based on animal data that are more or less convincing, and then a somewhat complex control arm of alkylators depending on how early you relapse after standard of care. And this is the best result, the best hazard ratio that we have seen in this trial. It also has a complex statistical analysis program. This is the combination of ABT414 with temozolomide versus the mixed alkylator control arm. And at least for the glioblastoma field, that really looks like a signal. But the drug apparently doesn't work, at least not if you take the same drug and move it into the first-line setting. The first-line clinical trial with a few hundred patients has completed enrollment a few months ago, and on May 17, AbbVie unfortunately had to communicate that this trial is negative, and it's really negative. There is nothing, and AbbVie has discontinued the development of this drug, which is heavily debated in our community because we have had so many negative trials, and the phase 2 trial didn't look so bad in recurrent disease, but after this result, the drug is being discontinued. And something that we are used to is that if drugs don't work, if the big companies develop them, we look for small companies to take over and reassess the drug, maybe in a recurrent setting. But I'm afraid at this moment the drug is dead. Next slide. We never give up in the glioblastoma field. We have another approach that essentially comes from Zurich. This is immunocytokines. Many of you know Dario Neri at ETH. He is in love with this construct of producing cytokines linked to antibodies that then go somewhere into the body to find their target. And one such idea is based on antibodies to fibronectin variants that are specifically associated with angiogenesis in tumors. And glioblastomas are very full of these variants of fibronectin that can be specifically targeted, not only and the blood vessels also in the tissue. And the first such drug compound is linked to TNF, and it works nicely in animal models, and the biggest experience is actually in sarcoma. There is a bigger trial, and we have now dosed the first 4 patients. At least the patients have survived that. There is concern about the safety of such drugs because if you imagine you have a lot of TNF around your blood vessels, hemorrhage is the major concern, and that may be more acceptable in the sarcoma arena than in the brain. But so far we have had not any problems. We cannot say anything about efficacy because only 4 patients have been dosed. This is a single center study that's ongoing. Now the main focus in the field is still on neutralizing immunosuppression emanating from the glioblastomas. That has been a topic in glioblastoma for many, many years, and it still is. And now, since we are also a bit opportunistic, we all move into the PD-1 arena like everybody else is doing, but also because these other approaches looking at TGF-beta, tryptophan metabolism, or STAT3 are not really advancing at great speed. If we look at PD-L1 in glioblastoma, we have a different set of data. It's difficult to interpret. If you look at TCGA, you find it, but of course in TCGA you never know how much signal actually comes from the tumor and how much comes from the host cells, because that is transcriptomic driven. The protein expression seems to be very limited. I'm going to show you data from the first phase 3 trial from CHECKMATE 143, where the expression is really low, at least if we look at the tumor cells, and then you can always argue that maybe we are not really able to distinguish tumor cells from the host cells, which may make up to 30% in glioblastoma. So whether there's a prognostic role, yes or no, it's really difficult to say. And what I can tell you is that it works very nicely to use checkpoint inhibitors in rodent models, but these rodent models are often very artificial because they are induced virally or chemically. They have a lot of mutational burden, and that may not really what we see in glioblastoma in real life. So I would like to guide you quickly through the data sets. This is something that I was already able to show you last year. The paper on this trial is still not published. I will show you in a minute why, what the problem is. So this is in the public domain. So this is first recurrence. It's driven by an American mindset. So that means that bevacizumab is the standard of care in the control arm, which is not approved in Europe in this case, but in the US. And the experimental arm is nivo alone. And there's nothing spectacular about the patient characteristics. What may be interesting is to see that if you look at PD-L1 expression with a BMS assay and you set the target cutoff at 1%, then only a quarter of the tumors are PD-L1 positive. Now, if you think about targeted therapy and you believe that 1% expression of tumor is enough, then you need to have a lot of fantasy to believe that this will work, right? Usually for a target, it should be a little bit more prevalent. But anyway, that's the cutoff that has been used. And then something else that is important to understand the trial results is the MGMT story. I may just quickly remind you what this means. The MGMT gene is methylated in the promoter region in a third of the patients, and these are the patients that have benefit from chemotherapy, and the other 2/3 who have no MGMT methylation have no benefit from chemotherapy, and that's a very important biomarker in glioblastoma. And then something else that is important for our understanding of these data is steroids, because glioblastoma patients, probably more like any other type of cancer patient, are often dependent on steroids, or traditionally have been put on steroids, and we want to get rid of the steroids if we use immunotherapy. That's also clear. If you look at the time on treatment, 3.7 months for Bev, 2.3 months for Nivo. That's already not a good sign, and you could really argue whether it's realistic to expect efficacy if you cannot keep the patients on immunotherapy for more than 2 months. These are the overall survival data. They are in the public domain like this since 2017. This is PFS, and if you think there is an effect, that's true, but actually it's not what you want, right? Because BEV is clearly better. But this is because the MRI is our endpoint, right? We're looking at MRI, that's an MRI-driven response assessment, and BEV makes our MRIs look better, at least if you have a tumor. And what you can also see is this staircase pattern of a curve. That's what we always see with, at least with BEV trials. That's always when the patient comes to the MRI, then some patients drop off because patients are progressing without being clinically progressive. That's a typical pattern. And then if you look at OS, then you see there's no effect, and I think you don't need a biostatistical super expert to see that this is a negative trial. Now, if you are from the US, you would say, super, now I have 2 active treatments, because BEV is approved, and Nivo also works, so that's super. If you are more academically minded, you would say, but where's the control arm here, right? So you don't really know whether you have compared to dead drugs or to alive drugs. That's difficult to say. And now I would like to discuss with you something that the referees at Lancet and Lancet Oncology found completely absurd, and we are still debating with them, and I think we have to step back a little bit with our interpretation. But since we're all biased, we love IO, otherwise you wouldn't be here. We, of course, together with the colleagues from BMS, try to find something that makes sense and that keeps the idea alive. So there are 2 observations here. So you know how to read these plots, right? A dot that goes to the left favors Nivo, and a dot that goes to the right favors BEV. And then you could, if you are realistic, you would say, okay, that's all noise, there's nothing in there. But this is difficult to accept for us, so we try to find something. So if you have a bit of fantasy, methylation goes a bit to the left and unmethylation to the right, right? I know, it's not a lot, but it could make sense because methylated patients get more temozolomide. And if you get more temozolomide, you probably have more mutational burden. It's all theory, right? And then let's look at another bit of noise. This is down here. If you are without steroids, you move a bit to the left, so you have benefit from Nivo. And if you have steroids, then you have more benefit from BEV, and that maybe makes sense because if you're steroids, you have bigger tumors, and then you are more likely to have benefit from BEV. That makes a bit of sense. But of course, it's all minor signals. But then you can start playing, and this is the figure that caused the hypertension with the referees. So what we have done now, you have at the left side, you look at patients who had no steroids, and if you have no steroids, the Nivo curve is the upper one. That's at least something. If you look at patients who had steroids, the curves switch. You can see that, right? Then suddenly the Nivo looks worse. And then we do the same story again for MGMT. We look at Nivo on the left, at bevacizumab on the right. And we are very honest, we have also shown that we have missing data. So the missing data for MGMT are in the middle between methylated and unmethylated, which also makes sense because they contain both. And then you compare, now you really have to be awake, you compare blue and yellow here. And I hope you can follow me saying that the distance between blue and yellow is bigger in the Nivo group than here. Almost double, which could mean that if you are methylated and if you have high TMB, then the Nivo can shift the curve, so the impact of MGMT gets bigger. And I know this is all hard to digest, and then you can push it to the limit. And this is the last horrible slide, and then I go back to science. Now, again, we have Nivo. It's only an S figure now because the referees were really angry. So we have 4 curves here and 4 curves there, Nivo and BEV. And the message from me would be, here, this is more or less noise in the BEV patients. But in the Nivo group, there's one curve that looks much, much better. And this is patients with MGMT methylation who are devoid of steroids when they start treatment. And now, if I would ever have the chance to do such a trial again, I would focus on MGMT methylated patients without steroids to try to show that IO works. So, where do we go from there? Like always in these days, BMS and Merck, they are competing and others are joining the arena. So long before these results became available, frontline trials were designed. One for MGMT unmethylated and one for MGMT methylated. The argument for this trial design here was that in unmethylated MGMT, temozolomide is so useless that it would be a home run to beat it. So we omitted temozolomide, although it's a standard of care, but we think it doesn't work anyway. So we put an Evo here and try to beat temozolomide. And here where we need the temozolomide, we add Nivo on top, controlled with a placebo. This one didn't work. Data is not in the public domain, but it has been communicated. Data will be released at some point. It's not really clear when this will go out, but the trial is negative, did not meet the primary endpoint, and we're waiting for that one. And that is going to be a very decisive time point for IO in glioblastoma. So let me quickly summarize what else is ongoing. I come back to EGFR. EGFR, this type of mutation went into a clinical trial, vaccination trial. It's published, it's completely negative. The community is very biased. Everybody loved this trial, this concept, but I can tell you, I know the data very well, it's negative. And then many of you, I think, know the dead horse theory. When you discover that you're riding a dead horse, the best strategy is to dismount. I think we all agree. But, for example, at the University Hospital, we have a lot of different strategies. You know, you create committees, examine the horse. And number 9 is also something that we do very often in oncology, harnessing several dead horses together to increase the speed. This is REACT. REACT is BEV alone combined with BEV plus rindopepimut, the negative vaccine, and the dead horses produce a signal. And we're lost. This is not published. We are lost now. They're very strong believers. They think this is really a good signal and we need to exploit that further. But again, rindopepimut has been discontinued by the company. But if you hear about these debates, that's the reason. This small trial, which is well done, is the reason why people still believe in that. But I think the list gets longer. With a few conclusions at the end, there are new developments around. There were these 2 papers in Nature, one mainly from Dana-Farber, one from a collaboration, Tübingen, Heidelberg, and Geneva, looking at a very, very complex type of individualized vaccination. There's not really outcome data in there. It's just a proof of concept that you can induce immune responses. We are doing similar things. Burkhard Becher has alluded to some of the work that we are doing here in Zurich together, mainly also with Tübingen, where we look at peptides that are presented specifically in glioblastoma stem cells. So we compare stem cells with bulk tissue, with normal brain, with normal tissues, and try to see what is presented here. We have some candidates, and that is work that is ongoing. CAR T cells are in the clinic, but the problem with CAR T cells for glioblastoma is the target, like every other CAR T cell project. And one major hope is, again, this EGFR V3 mutant. But what these colleagues have nicely shown here is that a single infusion of CAR T cells eliminated the target antigen, but not the tumor. And this is something that we have also seen in our vaccine trial, because in the vaccine trial, we looked at 60, 70 patients who had recurrence. And more than half of these patients had lost the target, but also in the placebo arm, which means this target is probably useless. And if I would have money to put on CAR T cells, I would not put it on CAR T cells that target an antigen that is probably very, very unstable. So we had a rough year. The main hope that we have is this one big trial on nivolumab, and we are waiting for the news any week now, and then we'll see how things evolve. With that, I would like to conclude. This is all what I have said already. Thank you very much for your attention.
Well, thank you, Michael. I know nobody who can so entertainingly talk about negative trials.
It's not all negative.
So, any questions to Michael? I remember in the olden days, the neurosurgeons, they put some stuff into tumors to elicit a response. Is the TVAC something? Is there anything, ideas, to put the virus in the glioblastoma?
Yes, there are a lot of ideas. Surgeons still like to do that, and I think that that's really an advantage of our disease because it kills locally. The biggest hype, at least in the US, was the polio hype. There was a paper in the New England Journal with 16 patients or so, but somehow this wave has also come down a little bit, but I think we will continue to explore similar approaches, so I think that's still on the table.
Thank you, Michael. Oh, there's a question, Bart.
Quick question, Michael. I agree with you that far too often we've been tempted to perhaps also go the easy way and immediately head for phase 3 trials, trying to get the drug on the market, while what's perhaps missing is really bottom up and verifying very carefully where we are in a phase 1-2 context. Alluding also to the fact that the development of combined IPI and Nivo was stopped because it was not very well tolerable in GBM population, but I recall from these phase 1 data that nevertheless some of the issues were with the fact that on this combination there was an inflammatory response. And of course, if there's one part in the body where you don't want extra inflammation and accumulation of edema, it's the brain. But shouldn't we have tried to learn more from those patients before heading into just Nivo monotherapy phase 3 trials?
That is certainly true. I think these very early IPI-Nivo combinations, there are very few patients and the data is not really rock solid. You may have seen, and maybe others, there is a Nature Medicine paper, first author Tim Clausi, which is very interesting design. They looked at recurrent glioblastoma patients who were planned for neurosurgery, and they gave one shot of Nivo, one single shot prior to the surgery, and they found that this one shot of Nivo induces a lot of changes. There's similar data for Pembro, so I think yes, it's a bit going back to the drawing board, but I would not give up. I think we need to do it a little bit better and pre-select patients better. I think it's not over yet.
I think something that's probably more of importance in glioblastoma, which is kind of contradictory because it hardly ever metastasizes outside of the central nervous system, is that probably a lot of those patients are there with kind of profound systemic immune suppression. A lot of them have low lymphocyte counts, and there have also been some publications that, and we don't know exactly why, that if a T-cell response ever occurs, it's blocked at some point, that T-cells are also kept within the bone marrow. Any news on inside what exactly mediates this systemic immune suppression?
It's still the usual suspects. I think still TGF-beta plays a role. The problem with TGF-beta is really that it's such a promiscuous molecule that it's so difficult to target. So I think that's still on the table, and we have been trying to convince them. BMS has a TGF-beta blocker. I would love to do a Nivo TGF-beta combination, but it's a frustrating market also for the companies. We have to be honest, right? It's also not funny for them.
Thank you, Michael.